My name is Dr. Luis Raez. I am the medical director at Memorial Cancer Institute, that is part of Memorial Healthcare System in South Florida. And I also professor at Florida International University. Talking about target therapies now and liquid biopsies, this is a very important topic because it's a standard of care to do sequencing of the tumors, so the genes, and next generation sequencing we call. And we are doing this in tissue, and it's becoming a standard of care. In America, there should not be a patient that has a new diagnosis of non-small cell lung cancer and without having the tumor sequenced and analyzed, because we know nowadays there is a 20% probably of the population that has one genetic aberration that can be used and can be targeted specifically for his treatment of lung cancer, and the patient will miss the opportunity to have this specific target therapy, and the patient will go straight for chemotherapy. It's not only that the chemotherapy is more toxic than target therapy, but also the fact that if the patient has a target therapy, he still can get chemotherapy later, and for that reason it's very clear that the patients on target therapy probably have a better chance of survival because they get target therapy first, and they still, when they fail target therapies, they can go and start chemotherapy like the other patients that don't get target therapies. The reason why liquid biopsy is important is because they give us the opportunity to diagnose and find all of these patients. A lot of times we know that all the industry vendors that we have, they are very successful in 99, 98% of the time in finding these aberrations. But what is real life is probably in 20% of the time, the tissue is not adequate because we do very small biopsies, because sometimes we find the lung cancer in fluids, like the pleural fluid, and all of these and other problems contribute to the popular belief that probably 20% of the time patients do not have adequate tissue for diagnosis and molecular markers. For that reason, we have only two options. We either repeat the biopsies, that is not easy in lung cancer because the biopsies have a risk of pneumothorax, as you know, and other comorbidities, or the other option is to do a liquid biopsy. That is the value of the liquid biopsy. We can add or complete the workup of the patient, bringing us the information that we need to use target therapy. And this is independent if you believe that the liquid biopsies will replace or not the tissue biopsies. That's a topic that is for debate. Some people believe that will do, some people believe that no, because the results so far have been controversial. But at least I think all of us agree that doing tissue and liquid biopsies were increasing tremendously the chance to find the genetic aberration if the patient has one. There is a lot of companies that do now even commercial liquid biopsy, and basically we need only blood samples, and there is even other companies that do urine samples, because the DNA, the tumor DNA that we analyze and mimicking a biopsy can be found in the plasma, can be found in the urine. So that's why sometimes for the patients it's very hard to understand why we call them liquid biopsies, but it's because we isolate the DNA of the tumor in the blood or in the urine, and we can always do that several times if necessary, because we can always get more blood or more urine, compared with the option to have to do another tissue biopsy with the comorbidities and the costs that they carry. The only disadvantage of the liquid biopsies is that, as I said before, there is a little bit of controversy if we are going to replace the tissue biopsies or not, but as I said before, at least all of us should agree that the liquid biopsies brings extra information for the patient care that is well needed to get target therapy.